Good evening and welcome to session 3 of our Health Policy Issues course sponsored by the TMC Health Policy Institute. I'm Stephen Linder. Tonight's session is on how policy is made, and we have as a moderator Dean Moultry from Texas Southern University School of Pharmacy. Dean Moultry.
All right. Okay, good afternoon. We will go ahead and get started. I'm Dr. Aisha Moultry. I'm the Associate Dean of Academic Affairs at Texas Southern University College of Pharmacy and Health Sciences. And so we have about 6 programs there that we facilitate under our umbrella. But today we are coming just as a broad healthcare perspective, and I have a few guests here with me to help facilitate our discussion today on how health policy is made. And before we get started, of course, I'd like for my panelists to take the opportunity to introduce themselves, give you a little bit of background about, what it is that they do in their own profession and what their experience has been with being involved in the health policy process. So I think I'll start here on this end, Dr. Capers.
Okay, good. I'm Willie Capers. I actually, whoa. Can you hear me in the back? All right, great. So I'm Willie Capers. I actually am on faculty at Texas Southern University as well in the College of Pharmacy and Health Sciences, where I've been there 5 years. So I'm a newbie to academia, but before that I was in practice in Arkansas. Before that I was actually here in the medical center as well. My primary work in healthcare policy has been through our associations, so pharmacy associations that I've worked with in Wisconsin, in Arkansas, and in Texas as well.
Hello, my name is Cedric Dark. I'm faculty over at Baylor College of Medicine and assistant professor of emergency medicine. I work primarily out of Ben Taub General Hospital. And my policy background is pretty much consists of running a blog for about the past 11 years or so, where I've tried to make policy research understandable to clinicians and sort of bridging that divide. And I guess we can go a little bit, I'll probably talk to you a little bit more about some of my background, answering some of the questions that we're going to discuss, but that's where I am right now. One of the things that I actively do is research on freestanding emergency departments, and that's sort of a policy topic that's pretty popular here in Texas, and especially in Houston, and it's something where I get to combine my clinical background with my interest in policy.
Okay.
Rodney Cox, Director of Pharmacy, currently at Memorial Hermann Health System. Thank you guys for having me. I've been in pharmacy for 20 years, and I've had the privilege of seeing it from the retail perspective and from the independent. So how policy impacts these different settings that I've been able to practice in, I hope I can share with you some of our stories and how we as a health system are trying to adapt to the many changes that are coming down the pipe.
Okay. Thank you. Thank you so much. And so really for the format of this is a Q&A. So I have some questions that I outlined and predetermined that were already posted online. And so we'll go through some of those questions that I'll be posing to the panelists, give them an opportunity to respond. But I really do look to the audience to join in and help facilitate discussion. If there is insight that you have on some of the topics that we bring up that we're talking about, I invite you to, just raise your hand. I'll go to the audience, to my panelists at first, and then after each round, I will reach out to the audience to ask if you have any insight that you'd like to offer as well, or if there are any follow-up questions that you have, feel free. So I do look at this as an interactive session and not us just, we're just up here giving it to you. So we do look forward to spending this time with you this next hour and a half, okay? So without further ado, we will go ahead and move into our questions. And so one of the big things when we talk about health policy is the role of interest groups, and what is their role and how do we get things to happen? How do they move up the chain of command? And so what's the steps? And so one of the things we want to talk about first, just to open it up, is the role of interest groups in public policy. And so Willie, I'll pass that to you to get us going.
Okay. Yeah. So I would say that the roles vary, as far as interest groups are concerned, I've had experience where one role is maybe more in the problem identification part, where we had to educate the public, educate lawmakers on the issue. So I've seen that where we put together information and we share that information with the community. But I've also worked on policy where in our association, where we drafted what the legislation would look like, shared that with health policy directors, kind of go back and forth to get it in a format that they can then gain support with and get it passed through the House and through the Senate as well. That was kind of fun. You know, that's more than education. It was very hands-on, and you kind of see the political jargon back and forth. Do not have this word, change this word to this word, these strategies, this type of way. So I've seen both, where it can be educational, but you can also go in and help craft some of the legislation that may come to the floor.
Have you seen it where, from all the way from beginning to end, where it actually went and passed?
Yes. So very recently, 2012, many of you may have seen on the news where we had a meningitis outbreak associated with compounded medications. So when that particular one was one that was very hands-on, once this happened, this of course drew a lot of media attention, and of course the federal government wanted to respond very quickly. So at that particular time, we worked very closely to put together language. We had a story. Of course, there were a lot of different groups coming in from different vantage points. And in this particular case, the pharmacy community had a different vantage point than the manufacturing community. Go figure, right? So, we kind of had to work together, and it was a very quick process because many of you may know that legislation was actually passed in 2013. So that was a very quick response to that particular outbreak. And of course, that was a federal response. Many states responded as well. So we had to do the same kind of work at the state level to make sure that it was aligned with what we were doing, both at the federal level, but what the states wanted to have as a result of it.
So your involvement initially was on the national level?
In that particular one,
Okay.
yes.
Okay.
Yes.
All right.
So I was working with our national group with the national
Right.
legislation. Yeah.
Okay. Okay. Right.
So I can talk about instances where it's failed that we've seen personally, certainly within our health system. I'm sure you guys are aware there's been a lot of coverage of the ACA and Texas' decision not to expand Medicaid. And so here's a situation where I would say pretty much every CEO you ask in the health system will tell you that the cost of uncompensated care is really hurting us. We have emergency departments that are open to the public because of EMTALA. And so EMTALA says that you have to be seen if you come into the emergency room, but it doesn't say you have to be paid as a hospital or a health system. So being able to get Medicaid to Texas to expand Medicaid coverage was huge for us, and we were not successful in doing that. So this is an instance where I think public policy may not necessarily reflect public interest, and it's because we as a citizenry don't understand the issues as well as we should. And the special interest groups gets to co-opt the conversation. So that's one big one. Another would be in our profession, pharmacists looking to become providers. The one thing about a pharmacist, you go into Walgreens now and you ask them for a recommendation for a headache or for a stomach ache, you get that for free. There's really no other profession that has that much training. You can't go to a lawyer and get free advice. You can't go to a doctor and get free advice. But in pharmacy, that's what we love to do. So we thought it'd be cool if they would rewrite the Medicare rules to allow pharmacists to be providers. And the CBO just looked at those numbers and said, nah, that's too big of a hit to the budget. So there's another instance where you have a strong interest group, ASHP, American Society of Health System Pharmacy, advocating, really made some inroads with some folks in DC that we couldn't get it across the finish line because there were competing interests out there.
Could I add one
Yeah.
example as well? So last session here in Texas, we had a bill go through that was actually passed regarding emergency department psychiatric holds. And so for those of you that may or may not be aware, someone comes into an emergency department in extremis, like they're suicidal, homicidal, or just so psychotic they can't function in the real world. Legally, we don't have the right as emergency physicians to hold them against their will in Texas. Other states where I've practiced, you can. But in Texas, there has to be what's called an emergency detention order, which can only be filled out by like a peace officer or a police officer. And so, for instance, let's say somebody's homicidal. I'll just randomly pick on someone in the audience. You, sir. Let's say your significant other is homicidal and wants to kill you. And they express this to me, and I'm like, they probably shouldn't leave. If I hold them against their will, I could probably face some consequences for, I don't know, kidnapping or whatever it would be called. However, I welcome those charges because I want to save your life and not let that person leave. You're welcome. And so essentially what we were trying to do for a few years now in the emergency medicine community is to pass a bill that says for 4 hours, emergency physicians are able to say, this person has to stay, we're not at risk legally for detaining them, that kind of thing. And that bill went through the House and the Senate in Texas, passed, and the governor vetoed it last session. Now, the reasons that he vetoed it, I'll let you guys look up on the internet. But it sort of gets at interest groups can come along, give good stories, create bills that you get everybody, to agree to, and then it actually passes, and then because of the executive branch doesn't actually turn into law. So where that stands now, we'll see over the next 140-day session whether or not that'll go through again.
Okay, so
Let me add one more thing.
Yeah.
I think I'd be remiss if I didn't say, of course, every interest group also, especially with the approval of political action committees, now have funding sources as well, both at state government level and federal government level. So, we did talk about educating and we did talk about working collaboratively, but we also know that some policy is accelerated based on funding, so all have political action committees or funding type sources that they use to support either candidates or parties, as well. So there is a funding role for these interest groups as well.
is there anyone? Yes, ma'am.
I would throw this out to the whole panel because you've each touched on it. Any issue is going to have multiple perspectives, and there are a lot of special interest groups out there that I envision many times come at legislators with different versions of the truth and different voices and passions. So in your experience, have you found any success with coalitions and trying to come together with one voice to come to legislators? Because I think they do get, it can be very confusing and discouraging to have so many people coming at them with different views. So have coalitions helped to speak with one voice?
Yeah, absolutely. So that's a great point, because in the compounding act that I was discussing earlier, there has been for a long time lobbying that has occurred from manufacturing groups to eliminate compounding that happens at a pharmacy, because just to let everyone know, pharmacies are run by state boards. They're governed by state boards. Manufacturers are governed federally through the FDA, two different sets of rules. So in that act, to bring us together and to work collaboratively, there are actually two. Both are recognized under that act, two sets of criteria. If you are performing the same kind of services as a manufacturer would, you are under those set of criteria. If you're not, you're under another set of criteria, but they are aligned, actually. So that worked very well in the provider status. I can't call it a success yet, but you may think that groups that represent the, let's say pharmacists, you say pharmacists, so there's one pharmacy voice, right? No, there's probably about 19 different pharmacy groups, federal pharmacy groups, not even counting what's happening at the state or local level. And so a part of that provider status legislation brought together a coalition, a joint coalition. All of their lobbying efforts are the same. They've agreed that we'll get together, we'll decide what they're going to be, but then at that point, we're going to all talk about the same bullet points. And what has happened is, and it's taken some time, as was mentioned earlier, it hadn't been successful. Actually, after that compounding, that went very fast. The second thing that I was working on was provider status, and we've been working on that for about 4 years. Now, at the federal level, it is gone, it's been introduced, it's been signed by a majority of not only congressmen, but senators as well. So it's kind of, when you look at policies, if you have over half, then that means that have signed off on it, then you will probably get that passed. But it hasn't been introduced to the floor in 3 years. So at each session, they have to start over. So positive momentum, something that hadn't happened in a long time, but the benefit of coalition had it pushed forward. Of course, we have a lot of different discussion right now about health care, so it's not really a priority. It was reprioritized, but certainly it's gained more momentum through a coalition.
And even through that, we do have some states who have passed their version of
Sure.
it. But just on a national level, that's something that we haven't gotten traction yet. Not where we want it to be, I'll say that. Yes, sir.
Mr. Cox, I wanted to go back to what you were saying about trying to get pharmacists the license to prescribe. CBS shot it down because, what was sort of the justification on their
The
part?
CBO? Just that it would be too big of a budget hit to have all of these pharmacists now tapping into that source of funding, which is Medicare funding to get paid. So they did.
They were expecting higher drug spend?
No,
Or
they just thought having a bunch of pharmacists billing for
Billing.
services.
Got it.
Yeah,
Okay.
was not in line with, I guess, their long-term model for how they're trying to contain costs. Yeah.
Can I answer that
In
a
this-
little bit?
yeah.
So sort of as one of my backgrounds, a little over 10 years ago, I actually was on Capitol Hill working for the Ways and Means Committee, which has jurisdiction over the Medicare program. So if you look at it from that sense and from the viewpoint of an appropriator, if you were to create a new provider type, and let's just say every pharmacy consultation, they get paid like $1
Right.
to talk to somebody. You know, however many pharmacists there are, times however many Medicare patients, talk to them and get a recommendation for what he says, like, what medicine do I want to buy? That's going to equal dollars and cents, and eventually is just going to be costly. And so if you're looking at it from the standpoint as an appropriator, you don't want to spend money necessarily, unless it's for a very good reason. Because otherwise, if you're spending money, you're either taking it away from another program, or you're going to have to raise taxes to fund it. So that's one aspect of it. And then, of course, that's even before you hit other interest groups that'd be against your coalition, one of which I could imagine I might represent.
Right.
And so we didn't even get into that yet.
Yeah, no, it's very interesting. I definitely understand that counter perspective of the physicians and the interest groups, but at the same time, I think that having people work at their highest license is very important. And if
Right.
you're talking about, if I go to my physician's office for a headache or something, they may or may not end up writing me a prescription. They're probably also billing for an office visit, tests, labs, et cetera. If I just go to the pharmacist, they might just bill for writing the prescription.
And
So
it's really not about prescribing more than it is about helping them manage the
Yeah.
treatment.
Yeah.
You know, that's really what the bill, what the proposal is about, helping. So if a patient goes and says, you know, maybe they go to the physician and now they're hypertensive, you know, say that for instance, and so they need help managing their hypertension, then the pharmacist could come in and help that. So it's really working in concert with,
Absolutely.
Right.
not against, you know, competing with, but helping the patient monitor throughout the process.
thank you. That was very helpful. I didn't mean to hijack the conversation, but I did have more of a general question on special interest groups. So it's sort of, I guess, from my perspective, a power struggle, right? And a lot of it's probably someone likes the status quo, someone wants change, and those interests are represented. Do you see any sort of trends in general amongst special interests that it's heading in a certain direction, or are there things that are currently in the legislative environment here in Texas or in the U.S. that everyone seems to be getting behind, and it's not so divisive amongst special interests?
Interesting.
I would say medical marijuana is one that's kind of caught us all by surprise, right? The medical portion of it, not the recreational. Stick with the medical portion of it. Because there's some real reasons that we're beginning to see for intractable seizures, for instance, in Texas. It's now approved. You can get the oil. There's a company that's now manufacturing it. But those things, when you're seeing the public face and they're having an opportunity to advocate in an effective way by seeing the patients to the legislators, it brings all of those special interests together. And we figure out, well, how can we find a loophole so that we can allow this for patients, yet at the same time not run afoul of the DEA. So that's one that I didn't see that one happening in Texas, as conservative as we are. And there are, I think, 3 or 4 bills right now being considered with expanding that to more orals and even inhalants. So we'll see where that goes. But watching that has been interesting.
Anything else?
I would just say anything that's gaining a lot of media coverage, you typically will have even divergent sides come together. So that compounding issue that I saw earlier, we saw that happen. We, of course, saw that with the swine flu a few years ago, Ebola virus that was fast-tracked. We saw it with that. Right now, what's ahead of us is drug shortages. Many manufacturers have been against any drug shortage legislation. Now that's really not the case. People are coming together to try to put something in front of us because now it's causing problems. So it just depends on what kind of traction media attention is getting, what kind of public outcry is happening. That typically tends to move people together and get something done quickly, at least on the healthcare side.
Okay. Oh, yes, more.
Sorry, you got me inspired to speak again. To your point about pharmacists being able to get compensated for their services. I'm a nurse.
Okay.
So for years and years and years and years and years, nursing has not been able to be compensated unless you're in advanced practice for their contributions to care. So to think about what the two of you said, it's not really so much about the pharmacist getting paid is recognition to their education of the patient and to the ultimate outcome of a good care outcome for the patient. So maybe, I don't know, I have hope in my heart that when we get to more value-based care, maybe you could envision coalitions of pharmacists, nurses, lobbying for those kinds of things, for bundled services that have an outcome that benefits to the patient through using the expertise of all healthcare professionals.
Definitely.
And the interesting thing about that, when we really get to an enlightened status, I think it's the day that you would see a nurse say, you know what, we could do this, but it's probably best if pharmacy does it. Or a pharmacist says, I could do it, but it's probably best that I advocate for case managers to do it. I don't think we've quite gotten there yet. We're still kind of in our silos, but it's getting closer. Yeah.
It's true. It's a bit of a turf war at times,
It is,
but that would be fabulous.
That would be, that would be.
I will add that I do think that once the model changes, we will see more of that because in capitated type of environments, you see it. So when we're not fighting for money, if there's just one pool of money and we need to do the best that we can with it, you do see more collaboration. You see it in county-based environments. You see it in VA type of environments. So in those kind of environments where we're not fighting over reimbursement, when there's one essential pool, you do have a team-based approach. So when that becomes the model, I'm sure we're going to have a more team-based approach.
It's trying to become the model.
I know it's trying. It's trying.
This is time. So yeah, just that whole interdisciplinary team. I think that's it. But that's where we're moving to. So okay, that was good on that that topic. So Rodney, I'll start with you on this one. Can you talk to us about the difference you see between presidential, so at the executive branch, congressional, and state roles in healthcare, and the roles that they play in the public policy debate and so forth?
Yeah, it doesn't matter what side of the, two-party system you land on. Bills need to get paid. And that's the crisis that we have really on my side of healthcare. You know, hospitals are closing at an alarming rate. You see a lot of mergers and acquisitions. It's all because we're kind of drive down costs because we're not getting the dollars for the cost of our services. And so no matter what the party in the White House or that controls Congress, we want to partner with them on solutions. I think there's some good things coming out of the Trump administration on drug pricing. They have some real good ideas about, let's benchmark our drug pricing against what's going on in Europe and what's going on in the world. Why are we paying the cost of some of these research dollars that companies have to spend are really being burnt on the backs of Americans? At the same time, there's some good things that, you know, we need to keep from the ACA. There's some good things that we are keeping from Nixon and Medicare. So we just gotta kind of get out of our own way, if you will, listen to each other. But from our standpoint, we don't care who's sitting in the chair, as long as they will allow us to have a seat at the table. But it's a little bit more difficult now because we're getting mixed messages out of Washington. So it's tough to really do good strategic planning and forecasting without some strong direction.
Sure. Did you all want to add anything?
Well, just kind of to reiterate a little bit of what he was talking about, I think the big thing that matters for interest groups is you don't really care who's in power at the time. You have to figure out what they can work on that's part of your agenda and kind of push that forward when the time is there. And if it's, you know, you might work on a few things that one party can help you with while they're in power, and then when that flips, you have to adjust and do what the other party is willing to do. Because ultimately, you're trying to work on your own agenda, and your own agenda doesn't necessarily fit party lines.
Definitely.
I will say it does matter, though. I mean, I hear that, and we would like to all work together, but it does matter. I think if you track what type of legislation was passed and what political parties had power, you can kind of see that maybe one group may favor one set of policies and another one wouldn't. I'll give you an example. When I was in Arkansas, we were talking about Medicaid expansion, right? And Arkansas, of course, is in the South, but it was one of few southern states with a Democrat governor, right? And at the time we were talking about Medicare expansion, this was the first time that Arkansas's state house was mostly Republican. First time in their history. So, and they elected a Republican governor. So do you think Medicaid expansion happened? Well, the answer to that is no. We said no Medicaid expansion. But the reality was the Arkansas Medicaid policies were accepting more patients than even Medicaid expansion would have. So it was kind of a political piece. We had an opportunity to expand it even further because a lot of Medicaid patients in Arkansas, but had a lot of underserved areas as well that could have expanded. So it does matter in what kind of policies would be supported. Another administration comes in that might support something else, it changes. I'm not saying one is better than the other. I'm just saying that it does matter as to what kind of traction you're going to get. And you will see that tension because, of course, they were getting a lot of pressure to support the national party, not necessarily what was in the best interest of the state. So it can matter depending on what the topic is, you know. So that's just an example of something. I could give an example where it didn't matter, but sometimes it does.
And I think that goes to understanding the political environment at that point.
Absolutely.
You know, and so it's just like getting a new boss or what have you, understanding what it is that drives them.
Right.
How do I approach them to get what it is that I need to get or that I want to happen? And so with change in leadership at the top, whether the top is state or national,
Right.
you know, then you may have to make your adjustments. And it's just political strategies, you know, how I would see it. Yes, sir.
I may be wrong about this, and that's not unusual, but I can't think of major health policy changes that weren't at the directive or pushed by a president.
Right.
You're right
I think
about
about the HMO Act.
Absolutely.
That's right.
That was pushed by Nixon.
Yeah.
Medicaid, Medicare, LBJ,
Yeah.
the Affordable Care Act, Obama. When a president doesn't have health care reform high on their agenda, I can't remember a time where we saw major policy changes.
That's absolutely right.
That's 100% true.
right.
There are those questions that have to be asked by our leaders, and they have to stick with those questions. I like the quote that Einstein says, and not that I'm smarter than everyone, I just stay with the question longer. You know, and I think sometimes as a public, we just don't have the appetite to stay with the question longer, and that's when you have to have those strong voices. But even at the state level, it works. We're seeing that in California with some issues that I think are personal to my profession, where the governor, with the help of Rita Shane, the director of pharmacy at Cedars-Sinai, wrote into legislation that pharmacy technicians or pharmacy personnel would have to do medication histories for patients in the hospital. Now you think about that and you say, well, why would you care if a pharmacy technician or pharmacy personnel does that? Polypharmacy is one of the big expenditures in our country, right? You know, as we grow older, you go to the doctor, what do they do? We give you a pill. You know, then we give you a pill for the side effect that the pill made, another pill for that, and next thing you know, you've got, 10, 15 pills that you're taking. So, yeah, I think leadership from the government, from the governor level, even on a local level, is exactly what you state. But we've got to stay with those questions long enough and not be distracted by some of these other issues that tend to pop up.
Sure.
Yeah.
And so it does go back to what are their priorities.
Right. Mm-hmm.
So when they come in, that is definitely, it does start from the top. They're going to drive, what's priority and what we should be focusing on. And so, yeah, and I would say we did see that when part of the, where Obama was pushing for ACA and it passed. And then when Trump came in, it was more of the reversal of, and so that was driving for quite a while. And now we have new policy that's being driven. So
Now, you gave a great list, but let's not forget George W. too. So Medicare Part D.
Medicare Part D, exactly, the precursor
Yeah.
to ACA, definitely. Okay.
Great list.
All right, good deal. Okay, so next, Cedric, I'll throw this one at you. And this fits right in with what we've been talking about. What changes have you seen in the policymaking process as a result of changes in presidential administration?
Yes, I think I kind of go back to how policy is supposed to process, more or less. And there's this old adage that, Congress in committee is Congress at work, which I don't know if you guys have heard or not. But essentially, the process is supposed to go, someone introduces a bill, the bill gets referenced to a committee, or referred to a committee, the committee sort of debates things, marks it up, has people come in, testify, that sort of thing, and then they decide, is it going to go forward or not? Assuming it goes forward, stuff from the House goes through their committees, stuff from the Senate goes through their committees, it becomes one bill that gets passed, gets approved by the president. And most people think that that's where lawmaking stops, but it's not really where it stops. After that, then you have the whole regulatory process, and you talk about the bureaucracies. And one of the things, especially at the federal level, that I think has changed, or that I've seen a little bit different from prior years, is that you're supposed to introduce what the rules are supposed to be, give the public a period of time to comment on it, change that around a little bit, and then introduce the final rule. And what I feel like we've seen in the current administration is a lot of like, here's the rule. And then people are like, wait, what? We don't like this. And then there's lawsuits and all this other kind of stuff that takes place. And then it's like, okay, here's rule here, but it didn't go through the right procedures, so you need to take it back. You need to open it up for public comment and then reintroduce it. And I think that's the biggest thing that I've seen. And I don't know whether it's just the folks that are in the administration, because maybe they're not as used to being in those sorts of positions as in prior administrations, that they don't necessarily understand the process, or if it's just the pattern in which the administration wants to proceed, that rulemaking process has changed a bit, at least in terms of what I've observed over the past few years.
Okay.
Yeah, no, I think we've got repeal but no replace.
Sure.
And so as an administrator, I don't get to have a lot of say in the replace, but I want to see it because I can start making policy decisions and decisions for my systems on it. So, yeah, we're in a really interesting space, I think, trying to react to this.
Especially, I think, because I'm thinking about when we had this discussion last year, and from last year to this year, and it was kind of a hot topic, but it had not died out,
Right.
And so now we'll piecemeal repeal, as opposed to fully repeal. But the question of replace has still been on the table. And what does replace look like now that we've all adjusted, making the adjustments to the ACA and what the ACA is saying, and, to go back and say, okay, we're going to repeal. We don't know what replace is. How does the healthcare system adjust? And so I do see that, as something that's a challenge where we should have the opportunity to see, have input, make our public comment, which is typically what we're used to being able to do, and, do that. So I could definitely see that. Anyone else have any insight or input you want to offer on that discussion? Yes, sir.
I'll just keep the mic.
I've got a chair. Open seat.
I look at the regulatory process of one which is really opened a backdoor on eviscerating legislation. And I think particularly nationwide at the anti-vaccine lobby that is using ways in the regulatory process to open up abilities to say no, they don't want their children or young adults vaccinated, and the consequences of that being the public health challenges we're having in Washington and elsewhere in the nation. I don't think a lot of that's being done with direct regulation or direct legislation. It seems to be more on the regulatory side. And that's one way in which policy seems to be being made, which is of direct negative consequence to the public health and the public good. And a clear example of how aligned interests of physicians, pharmacists, pharmaceutical manufacturers, public health people have been unable to stop and to change that culture. And it's really scary.
Yeah. Who's really making the decisions becomes a discussion.
Right.
Is it really the healthcare professionals who know? Is it the lobbyists who are getting a lot of money? Who has the true impact on making those decisions? Is it somebody's friend who, we owe a favor to? And so, that is a scary time, scary thing. Okay, so Willie, I'll go back to you. So what are some strategies that you see used by interest groups to influence public policy? Just given your examples you've made.
Yeah, I've sort of alluded to at least some that I've been involved in. One thing that I didn't mention that is also a strategy is, our different days on the Capitol or whether that's at the state level or the federal level, where you may take a group of the community. And I've seen that because a lot of times if you take healthcare professionals, they come in there and they know, hey, you're well informed about this. But at the same time, I'm in this elected office by my constituents. So I see a strategy of interest groups gathering constituents, training them on that particular issue, and then taking those constituents to meet their representative and discuss that particular issue. I've seen that work very effectively, but there's an additional thing that normally occurs that at least some of them, and you would know this better than me, but they talk about something that's really a manufactured interest for the community or a true interest for the community. So if they're getting multiple inquiries about the same kind of thing and these people aren't associated with each other, then maybe this is something that we should take a closer look into. So while those events that you may have where you bring a group of constituents there to discuss with them, an additional strategy is having those constituents on their own call the different representatives to express that interest in addition to what they're doing. And they get reprioritized. I've seen where certain issues where we would, and I'm not saying anything negative, every representative has a staff, and I can tell you most of the time that health policy person is the one that's most educated on health policy issues. So they're great to talk to, but they're not the one that's going on to the floor, so you'd love to speak with your representatives. And I've seen where if it's just the healthcare professionals that are going in, sometimes depending on what the issue is, you will only get a staff person, but then once you start bringing in constituents, depending on whether calls have been made or if it's a large enough group, you'll definitely start seeing the representatives and things start to move a little quicker.
Yeah. Yeah, I would definitely agree with that. I think the having someone from the community, they always like a story,
Right.
you know, and so having that story to tell, you know, once the representative gets behind it, identifying that person who can come in the store to help sell it, if you will.
Right.
That's definitely something that I know has worked.
Another
Yeah.
strategy before I forget, I said I wasn't trying to paint the media portion in a negative light, but I know sometimes we have stories that come up, but also special interest groups utilize media through any kind of interviews or panels that they may have, focus groups, but also maybe about 7 or 8 years ago, I was involved in a commercial series that we were running to educate the public on this particular issue. We did public service announcements. They did actual television commercials. Very, very interesting. I'm sure most of you have seen commercials where there was a person in a classroom, then you saw a accident on the freeway and someone rushed to help them, and then at the end of it, and it says, it was talking about how much we love our nurses, why don't you become a nurse? So it was the same group that worked on that particular campaign, where we were working on a similar campaign, but that's what that interest group educates the public on whatever this issue is. Of course, that brings at the top public interest, and of course now they want to see something to occur, about that. So I've seen that as well, whether it's radio or television, where you've seen that kind of strategy to help motivate the public.
Okay.
If I can share one example that recently occurred kind of within the emergency medicine and the overall medical community. Back in November, the NRA was talking about how doctors should stay in their lane regarding gun violence issues. And, I saw the tweet. By the way, if any of you are on Twitter, follow me at Real Cedric Dark. But I saw the tweet, and I was, and a couple hours later, the whole Thousand Oaks shooting thing happened. So I sent like a little snide retweet of the NRA thing. I was like, y'all couldn't even make it 12 hours before the next mass shooting. Then I went to go work at Bentop. And, then there's a car wreck or something. I'm sitting in the CAT scan machine with the patient, and of course, since for those of you that have never been in a trauma bay, getting a CAT scan done, it takes a long time because they got to hook up an IV, and then the tech's got to do stuff. So you got a lot of downtime. So I'm on my phone, checking Twitter again. Disclaimer. Don't tell my bosses. No, but it's actually okay. But a couple of us started getting fired up over that time frame, and one of the guys who's in Maryland had jotted down some thoughts, and we need to respond to this. And what we essentially did over the next 24 to 48 hours is probably about a dozen ER doctors and maybe like a couple trauma surgeons. We kind of were sitting there on Google Docs just composing things that turned into op-eds that we got into the USA Today and the Houston Chronicle, and some folks were then on CNN, and I think Dr. Oz and all these, and we're kind of using sort of a media moment to talk about an issue that has been a big issue for us. But I think the thing that made it more of a story, a media moment, is because we actually were saying something about it, which in the past physicians had not really said that much as an entire group. And so kind of became something bigger, and we're using media as a tactic to keep pressure on that issue. And then, of course, since the election had also happened fairly recently around that time, you knew Congress was shifting, then people could kind of go to their back channels a little bit, and the connections that they already had with people on the Hill, people in the Brady campaign, or Giffords in Everytown, and Mom's Demand, and all those other advocacy groups that share a similar point. So that then, by the time the new Congress got inaugurated, they could actually introduce some legislation. So that exists now. I do not remember the bill number, but I can look it up and get it to you if you need it. But again, one of the guys that's there on the Hill during the bill introduction is Joe Saccharin, who's a trauma surgeon out of Hopkins, so it makes it easy because he's there. But these are people that were in place, and it's just you have to use a moment to kind of leverage the interest that's there, so that you can make something that you're focused on into a bigger thing than it is otherwise.
Yeah. No, that's good. I do remember that because that was different, for the physicians to come out and, and then even when NRA made that comment, there was the rebuttal. We're not just gonna take, whatever it is you say, but we're coming back with our statement and supporting it with our role and why this does matter to us.
You know, I think special interest groups, they just do it better than, I guess, the general public in terms of the organization. And one instance that I'm thinking of is with our State Board of Pharmacy. The retail chains just showed up. Sometimes it's just showing up at the board meetings, right? They're open to the public. So you get an opportunity to face-to-face and interface with the policymakers. And there was recently some legislation that was passed that allows for retail pharmacies to open up pharmacies without pharmacists. And now wrap your mind around that for a little bit. It's coming to a rural neighborhood near you. But that's one of those situations where our special interest groups, as you stated, the coalition wasn't coalesced, if you will, making up the word. We weren't together. We missed this one. And the big retail chains kind of did an end around and got in front of the board, and next thing you know, it's done. So I think the rule is you can't have a pharmacy within 25, 30 miles or so from another retail pharmacy. But if you're in a place where, your local CVS is 50 miles away, I can open up a pharmacy and put a couple of technicians there and have a pharmacist remotely tap in and verify those orders. So sometimes it's just about showing up. All politics is local,
We've talked a lot about associations and others as a part of a special interest group, but even to your point, large corporations are special interest groups, and they have a lot of power. All of the large corporations that I've ever, worked with have had lobbying departments. That's not a part of their core business, but it is a part of their core business. That has occurred where they have a lot of influence over different legislation, that occurs, and how things are interpreted by the regulators as well. So, post-implementation. So I've seen both of those things happen, and folks who don't think that large companies have that kind of power or interest in what's going on or can be fooled by things that they think just arbitrarily happen.
And even the public sector too has, like Harris Health has its own government relations unit because they still have to negotiate things with the state. So
Of course.
And I would just add, you can go ahead.
You guys are starting to move into the same vein of thinking that I was, and honestly, I was kind of spiraling down conspiracy theories since Willie started speaking first. But whether you call it, industry interest, special groups, it's not too far-fetched of an idea to think that there's a lot of manipulation through data mining, segmenting of the population, et cetera, that they can actually kind of create what seems like a very organic group of constituents to bring a plea to their representative. And so I'm just, it's probably certainly happened before already. How big of an issue, how prevalent do you think it is? And then is it data privacy and clearing of histories? I mean, what can sort of be done to address some of that?
Whew, that's loaded.
I don't know what can be done to address a lot of it, but I've seen sort of some of the concerns that you have, because recently I was looking at something where there's a advertisement that kind of came out talking about how Medicare for All is terrible and evil and whatnot, and it was funded by some organization whose name I can't remember because they probably were just made up, but they get their funding from like everybody in healthcare, like pharma, the AMA, some patient organizations. So it's like a lot of these random groups that you don't think are going to play nice with each other. What they do is they take their money and they put it in some other kind of organization, and then that organization runs an ad campaign doing something. And I think there's a lot of money floating around to try to influence people in various ways where you can't track back to where it originates. And so you don't really know who's lobbying for what. Another sort of example kind of from my time on the Hill, as someone who was working for the staff of the Ways and Means Committee, we would have people come to us to effectively lobby us. And, sometimes they would usually come from big organizations or associations. Like I can think of like the National Kidney Foundation, because I was working on something on end-stage renal disease at the time. And so there's some organizations that you hear about that already have some clout because they're big and they're well known, and there's other organizations that might be talking about things, but if they're not as well known, they may not have the same clout and may not get listened to as well. So it doesn't really answer your question as to how to fix any of that, but I share your concerns.
Yeah, your concerns are very real. Again, the part about fixing it, I don't know. I don't know that part will happen, especially if you look, again, in the healthcare space, where you see large corporations, Apple, Microsoft, Google, Amazon, are now coming into the healthcare sector. Now, some will say, well, why? I wonder why. Of course, they're saying, we're going to drive costs down, right? We're going to make it cheaper. But when you really look at what those companies specialize in, they specialize in data. And the Journal of American Medical Association, there was, I want to say a few months ago, was an article put out looking at the strength of direct-to-consumer advertising and how powerful it is from a health policy perspective. How once we start direct-to-consumer advertising over an issue, how that issue becomes priority, how much money follows that particular issue, how changes occur. So, in that part about now that I have data, I can target it into this particular group, I can move the needle on that particular issue very effectively. So with very large companies with endless amounts of money, I don't know that we can stop it, on that particular part, but we should be concerned. We should follow what's going on, and we, of course, should make sure that it's being used appropriately. I remember when direct-to-consumer advertising first got approved, we were arguing over whether or not it's beneficial or not. And there are different people that can say it was beneficial or not, but we know that, of course, in the hands of the wrong groups, it may not be very beneficial.
Okay. All right. Okay, so next I will follow up with Rodney.
Yep.
How can interest groups and political parties influence government policy in modern day America?
That's a good question. Seems like in all the wrong ways nowadays. I think the most important thing is we have to shape the dialogue. I think Bernie Sanders, and I look at both parties. I love politics. I like listening to hear what these guys have to say. Question that he kept asking during his time on the national stage is healthcare a right? And that's a question we still haven't answered yet, right? So it's really just staying with that question a little bit longer, not getting distracted with these other issues. Let's just sit and let's just think about that for a little bit. Because then you start to think about, well, is it a right that's being guaranteed to some people? Well, yes, if you're really old or if you're really poor, right? So we already made that decision, but we really haven't stuck with the question long enough to talk about, well, what about all the guys in the middle? So yes, political parties, you're seeing it in California where they're pretty much going to unplug from the matrix and do their whole entire healthcare system on their own. Very similar to what Romney did, to be honest with you, but even at a higher level. So yeah, I think the political parties, unfortunately, they do drive the conversation.
Certainly.
I think it gets back to money again, too. So when you look at interest groups and then you look at politicians, and when I was driving here today, I was kind of listening to the POTUS channel on Sirius. This is not an advertisement for Sirius, by the way. But they were talking about how there's all this polarization with the political parties, and you have, everybody, the Senate, Mitch McConnell essentially is running it, and everyone has to fall in line if you're Republican, and Nancy Pelosi is running the House, and if you're Democrat, you got to fall in line with that. And I think there's this whole thing with like political action committees, which you've talked about. So if you are a political action committee or an advocacy group, you collect your money, you distribute your money to candidates. Money buys you access to those candidates. So I've certainly done some of that as part of an advocacy organization where it's like, hey, we're going to give you a check. And they're like, oh, great. let's have lunch, you know, and then you can sit down, you actually get a chance to sit down with a member and talk to them for 30 minutes or so while you're eating some food and drinking some coffee, and you get a lot of in-depth conversation, whereas when I go to the Hill to visit them in their office, it's usually you're getting the health LA or someone along those lines, because there isn't that money transaction. It's just, hey, you're in my office, you're kind of a constituent, we'll listen to you a little bit here and there. But money is what drives that conversation. But on the other end of the spectrum, you have the PAC money coming from both of the parties. And a lot of candidates now actually get a lot of their money from the parties themselves. And so you have constituents or interest groups telling them one thing, you have the party saying, you got to do this on the other end. And so I think there is somewhat of a conflict there, because where are they going to go? If you're still, you know, congressperson's job every 2 years is to get reelected, you know, and you got to do what it takes to get reelected. So one, that's doing what's best for your constituents so you can get their vote. But number two, it means having money to be able to fund advertisements, and so that people actually know what your name is, so that they can vote for you.
The one, I guess, example that comes to mind that defies the logic, again, goes back to Medicaid expansion, right? This was free money given to Texas.
Yeah.
And I can't think of who's the special interest group that doesn't want free money. You know, that's a political decision. That's not a decision that's based on constituency or any interest group that I can think of. Everyone benefits from free money. Maybe one of you guys have an opposite opinion on that. That's just one that was a head scratcher to me.
It's not free money, it's taxpayer money.
It is taxpayer money. That's true. That's true. All right. That's true. That's true. It is taxpayer money.
Yeah. And you know, I'm going to use a horrible example, but to anyone who has played a game called dominoes before, there's a saying that all money isn't good money. You know, so just because you take money, that can hurt you in the long run. And I think when it comes to certain things like that, the political parties have a large influence. And to your point, certain candidates that have not been established for very long, most of their money does not come from fundraising, it comes from the party. And so if the party says, we don't want you to accept this particular policy, they will not. Because that means that if they do, we will run an ad campaign against you and you will not have this job for very long. So again, that's where you say, well, it's good, we can make it happen, but if it stands in the way of me getting reelected, or what we've seen in this interim or midterm election where we lose seats and that may change our influence or power for our entire party as we're doing things, well, then it could cost you politically, which the only reason why I say that is we're in an unfortunate situation right now, especially when it comes to healthcare, where, you know, the word compromise and coming together to come up with one particular set of rules, some influence from over here and some influence from over there, it seems that that process may be gone, you know, especially when it comes to healthcare. Either I get my way or you get your way, but we won't compromise. So we have to, you know, learn that piece of it, that, yeah, some things that may seem good for everyone may not be, especially when you talk about the power of political interest.
So to speak to Mr. Cox's point, there is a different perspective if you impose federalism on what's happening in Washington and how we understand the states' roles. The states that turn down the free money with the Medicaid expansion have waiver applications under consideration with CMS.
Yeah.
Texas believes, on some level, that it's able to do more with an 1115 waiver than it could under expansion 10 years out.
Sure.
Because they're expecting the waiver to be renewed and have been given reassurances. And the other 15 states that are in the queue right now believe they can cut a better deal than following the rules of expansion and being bound by what the future of expansion means for state budgets.
Sure, and I think DSRIP dollars target certain communities and certain diseases, but I still don't get to say no at the emergency room. I've got to take them all. You may have DSRIP dollars for diabetes, But that HIV patient that's unfunded comes through the emergency room, we still have to pay for them. So we still have to answer that question, who pays the check? You can't go into a restaurant and buy food without paying the check. Someone's got to pay the check for this care. Or would you prefer a hospital to say, no, we're not going to take you because you don't have any insurance, right? No one wants to talk about that question. But luckily, we live in a society where our hospitals are open to the public, and we will do everything that we can. You know, you can have Medicare, Medicaid, or no CAID, and you're going to get the same care at Memorial Hermann. That's a beautiful thing about our business. But in the end of the day, no money, no mission. So we've got to figure this cost strategy out.
Sure. Anyone else? Okay. All right. Okay, this is our last question, unless there's something else that comes up out of the audience. And I'll start with you, Cedric. If you can talk to us about the iron triangle model of policymaking involving Congress, the bureaucracy, and the interest groups.
Yeah, so this is just kind of more of an academic thing, and I'll try to keep it short in case there's other questions that you guys want to hit. But the iron triangle is essentially you have Congress at one point, you got interest groups over there, and you've got the bureaucracy, and I think we've talked about all of them at some point. Essentially, Congress has authority, either budgetary or otherwise, over some area of the bureaucracy, right? So Ways and Means Committee has control over a lot of the Medicare program, and perhaps, I'm not exactly sure if they do, but let's just say for the Ryan White program for HIV, right? So if Congress has control over that part of HRSA that does the Ryan White program, then you have interest groups like people with HIV, AIDS, and those patient advocacy organizations. So pretty much, each one of these other organizations, each one of these points on the triangle is trying to prop up the other. So the interest groups go to Congress and say, you know what, you need to make sure that you give money to fund this program. They go to the agency and talk to the agency to try to make the program run well. The agency, on the other hand, is like, hey, I like being a bureaucrat. I like my job. Let's make sure that the federal government gives us more money so we can all stay employed. Let's keep the interest groups happy because they're the ones that are using our program. And then Congress, you know, is doing the exact same thing. And in short, the iron triangle is the reason why you can never cut anything out of the federal budget. Because there's this group of people on all sides that have a protected interest in keeping whatever program is alive. And so even if a program is, you know, could be better accomplished in other ways, they're not going to want to get rid of it. So for instance, and this is where I say this controversially all the time as an example, and will probably piss off some people when I say it, but let's just say let's end the Ryan White program. Get rid of it, you know. Why do we need it? Because maybe we could just replace it and say, you know, right now we have Medicare. Medicare goes for people over 65. It goes for people with end-stage renal disease. It goes for people with ALS. Why don't we just say if you've got HIV, you get Medicare? So we have another funding stream. You can kind of replace things. But the people that are in that triangle are probably going to be like, nah, I don't want to do that, because the fear of losing everything and the fear of something new probably is going to outweigh keeping the status quo alive.
You all have anything to add to that?
No.
No. Now, are there any questions regarding that or any other topic that we've discussed tonight? Yes, sir.
I just had an idea when we were sort of talking about you're going to receive the same care at Memorial Hermann, which I think is fabulous. There was recently, I guess this would come through the agency and the enforcement piece through the White House, but charge masters have to now be published, and I know there's a lot of pharmacy expertise on the panel. And so just briefly, if you could kind of talk through how that came to be enforced now, and then sort of what are short-term and long-term effects that you would expect from something like that?
Yeah, that's interesting. I think we just published ours in January. So you go on our website, you can see how much a HIP is going to cost you. I can just say from our perspective, from a pharmacy standpoint, we do our very best to make sure that the charge master reflects the most current pricing that we're getting for drugs. And there's so much bundle payment going on now that I don't know if that teases directly to what you see on our website. But that policy is definitely prioritized, making sure that charge master is as clean and as good and as updated as often as possible. It's definitely a priority for our system. Yeah.
This is an example of now we see something occurring, but this has been going on for a while. And I remember when this whole price transparency argument started happening, many news outlets started publishing different bills from different hospitals and saying, oh, when you go over here, they charge you $500 for aspirin, whereas over here they don't. And I don't want to get into why, because of course I've been on the hospital side for a long time, and I understand why pricing strategies occur, and no one is paying that price, and even if you're paying cash, but of course, no one wants to hear that when they say, look at the bill though. But what I will say is I think that while I'm for price transparency, I'll tell you, when I go into a restaurant or when I go into a store, I want to know how much it costs. If I go into a restaurant and there are no prices on the menu, I say, I probably can't afford that restaurant. So I leave. And that's really the experience that we have in hospitals, right? I have no idea how much this is going to cost me. I receive the care and then, oh my God, right? So I say though, what happens when now everyone knows how much it costs? And you got to think about, we may say elective procedures, or I'll pick on you, going to the emergency room. Because we know that we have sectors of our population that even when they need to go to the emergency room, they won't. And most of the time that sector may be lower income. So if I look on it and I say, well, my knee hurts, and someone says, oh, you probably need to go in and let them check that out. It's like, oh, it's going to cost me $5,000 to do it. Will they go? So I think that's what we're going to see, some dangers of that people may not receive care that they might need because they look at a price and may not understand that price fully, that they may not have to pay $5,000, that there's a portion that their employer pays, here's their copay. They may not go through that entire process to discover what their out-of-pockets might be, on that. They'll just see that price and then they'll not receive care.
I believe my view on this is a lot more skeptical, though. I think charge master prices are complete fiction, and they're just random made-up numbers. So I don't think it's ultimately going to change anything because nobody other than the self-pay patient pays the charge master price, and of the people that actually pay it, coming from ER, I think the collections amount on self-pay patients is somewhere about 30% or something along those lines. What you really want is you want an all-payer claims database because you actually want to know, what does Aetna pay? What does Blue Cross Blue Shield of Texas pay? What does Cigna pay? What does Medicare pay? And we can look up, I can give you a diagnosis code and look up what Medicare pays. But you can't do that for those other organizations out there because that's all proprietary. Sure. And that's where, if you really want price transparency, that's where you got to go.
That's where it is. That's right.
I was just thinking back to what you said, Willie, about it may cause somebody not to have a procedure, but isn't that up to us as providers, regardless of what discipline we're in? I'm a nurse, but isn't it up to us to be sure that we're representing the information that they need? So it's not okay just to have prices out there, but they're not really going to pay them, but we don't bother to tell them that, because it's too complicated or too complex. And, so somehow that responsibility lies within the system, it seems like, to figure out a way to get that out there. And maybe part of what you're saying is like the answer, or part of the answer to that. So.
Right, and that's what I was going to say. I agree. I do think that patients should know, but the level of information that they should know, that's the part that really the lobbying against that part of transparency is occurring, where you won't know. And that's where the large companies are, and they're saying, no, we don't want you to know what the negotiated rate is. Let's make them post this fictional rate so that now the onus is on the healthcare providers to explain why it costs this. And so that's what I'm saying, it's misappropriated.
And I'm gonna come to you just to tag on to that. It to me is similar to the direct-to-consumer advertising debate. How much information is too much information, or how much is too little? How much do we provide, and how do they use that information that they receive? And so if I see a commercial and I'm up and, oh yeah, maybe I do have insomnia. I need this, doc. And it's like, well, you don't know the whole story behind the diagnosis. No, but I gotta have it. The commercial said these are my signs and symptoms. And so I think it falls in that same way, like how much information is information overload to where it is countering our full intent of the transparency. And to me, it falls in that type of debate. Yes, sir.
I think we're probably shortchanging what's going to be happening down the hill. This is, I think, step one.
Yeah, of course.
And I think two things are going to happen from step one. The first is there's going to be a ton of consulting companies that are downloading all the charge masters of all the public and private hospitals in the U.S., and they're taking this big database and they're looking for variations. They're looking for what happens when they bundle, when they don't bundle, and they're going to use those consulting services, go directly back to the hospitals and then go back to the insurance companies. And so it is a consultant's dream, number one, to look at the huge variations in charge masters. Because as you know, the charge masters are, you called it fiction, they're across the board. The second thing is somebody in TMCX or in J Labs or in the AT&T Labs or whatever is going to figure out what the right bundling things are for the CPT codes and the DRGs, and they're going to have in their hand an app that is going to be able to bundle those things by diagnosis. So while you see this, cut X here, do this, that, which you can't make any sense of right now, but when they get bundled, you're going to know this, well, this is wrist surgery for X, and it's going to typically be this, and it's typically at this rate. So they're going to somebody's going to develop the bundling app that they're going to start looking at, and then as they realize that still this stuff is somewhat abstract, but the negotiated prices are that, they're going to end up saying that the privacy clauses and the exclusive clauses in the contracts between managed care companies and hospitals are not valid. That information is going to have to be out there. And so what we're seeing is the beginning of a transparency process. And 5-10 years from now, this is going to be an entirely different conversation.
I hope it's only 5 to 10 years from now, because if you've noticed, a lot of those pricing warehouses currently exist, right? It's our large health insurance, or what's happening in that market. They're being purchased by providers, whether that's pharmacy providers or other companies that are looking to get in healthcare. So that's the beginning part of the data. What I can tell you is that some of those, they're not called apps, but some software that does that already exists. It's just not available to the consumer. So that's not a far-fetched idea to now make it available to the consumer in various things. But again, I agree with you that that's the portion that has to be the part that's shared with the consumer, not the charge master.
And even when it is available to the consumer, studies have shown that they don't really use it well.
I was about to say that too.
So, but I think I agree with you. I think where that information is going to be used is going to be in the negotiations between insurers and providers, because they're going to be like, oh yeah, I'm just going to say this because I see Methodist over there. You charge way too much, and what we actually pay is way too much relative to, Harris Health. There's so much more. There's so much more cost beneficial, So once they get that information, they'll probably start to play people against each other a little bit.
Of course.
So.
Okay. Any other questions, comments? Yes, ma'am.
This may be a naive question, but back to the topic of how health policy is made. I'm curious about, and I don't have a good example, but you hear that, well, this bill made it or it didn't make it through the legislature because they've tagged this onto it. Can you speak a little bit to that process of how you think a bill is going up with this one topic, but then it may have something that's totally unrelated, and I don't really understand that.
Yeah, it's kind of the concept of riders, I guess, and other little bills that are out there. And then if the people that are shepherding these bills through the process are like, oh, we've wanted to get this across the finish line, but we just quite weren't there. But now, there's like this huge bill that we know has to pass and everyone's on board with it. If it's not going to piss off enough people by throwing this in, let's just kind of attach it to it and get it over the finish line. That's more or less how that works.
So does it work in the opposite way, or is it just to get things across the finish line?
I mean,
Can it be detrimental
Happen.
It could be. If you put something on there that enough people are opposed to, then you could have something that was flying through, and then you tag a bill in there that's like a little, kind of what they might call a poison pill on there, and then everyone's going to balk at it and be like, no. And enough people fall off of it that the bill stalls. But that's part of the process of leadership in terms of knowing where their votes are, and making sure they have enough votes to get certain things done. 'Cause I think you kind of alluded to this before, like if you're one of those junior members and you get all your money from the party and the party says, we're going to throw this extra bill on, and you might be a little bit opposed to it, but not to that point where you're going to threaten pissing off everybody in your caucus, then you'll be like, okay, I'll let it go through.
Okay. Anything else? Okay, well, good. I think this, we finished with a little time, about 10, 15 minutes to spare, so that's good. I definitely want to take the opportunity to thank my panelists for coming out and participating. I want to thank the audience for adding to the discussion. I think it's been a real fruitful discussion.
Yeah.
And so, without further ado, we'll call it a night. Thank you.